hurrying up, but unfortunately I've got a flight to catch, which is why I need to start off. So I'm not an interventional pulmonologist, but I do interventions. I'm keen on doing them, and I have got colleagues who do them better than I do. So this is Dr. Lokesh Gupta asked me to do a talk, this is going to be my philosophy, my thinking, my experiences, insight. And this won't be a talk about how to do EBUS, but more about what I conceive of doing EBUSs and doing interventional pulmonology. So a little bit about the history. So like most of the techniques that we do in respiratory medicine, EBUS first came in gastroenterology to look at gastric and esophageal malignancies. And then the early 1990s, the first use of ultrasound in the airway was developed. And at the time, there were small probes which were called mini probes. Interestingly, radial probes came in before the convex probes that were developed. So the mini probes, the first generation of radial probes came in the 1990s. And then when real-time transbronchial biopsies, real-time samples need to be taken, you had in 2002 the first convex probes coming into being. So this is my journey. I started off in this small department, chest and cancer block in IPGMER, the Institute of Postgraduate Medical Education and Research. I was my mentor, and that's the hospital. There's a lot of talk about hospitals in Kolkata just now. This is our premier postgraduate institute, which is, like I said, the SSKM Hospital or IPGMER. I went to the UK for further training in 2001, and there I got trained in basic bronchoscopy, thoracoscopy. It was all flexible. In the UK, rigid bronchoscopies are done by cardiothoracic surgeons, so I learned about putting in metallic stents through fiber optic scopes, and I completed my training in 2006. In 2006, I got my first job. I got a much coveted consultant job for a gentleman called Professor Martin Muirs, who used to lead the lung cancer team in Jimmy's at the time. And I got that job. But in the process, I had to do a lot of things which I was not trained in. So convex probe, EBUS was there, autofluorescence bronchoscopy was there at the time. And the patients who had the procedures were all recruited as part of studies throughout Europe at the time. So when you're thrown into the deep end, you have to learn and do it, and that's always difficult being a consultant. But just to talk about the procedures, that's radial probe EBUS. You've seen Dr. Nagarjuna describe this in great detail. The radial probe which goes in through your ultrasound channel, and the 360-degree view that you have of the parenchyma and the solitary pulmonary nodules that you see in the process. And that's the convex probe EBUS, where you see the image of the needle going in, and then on Doppler ultrasound, you see the vascularity of the structures nearby, and to avoid these structures is something that you need to do. So in trying to learn these procedures, I used to travel twice a week to Royal Preston Hospital, where Dr. Munawar, with a written MOU for my training, used to train me at Royal Preston Hospital. That's how I learned EBUS. So the distance is about 200 miles. So I used to travel that to and fro twice a week during the time. And I did so for about 3 months at the time to get my understanding and my certification in doing EBUS at the time. Come back to India in 2009, feels strange, that's about 15 years ago now. And all the units, so that's Apollo Hospital, then Fortis, and then the Birla Group of Hospitals, the CK Birla Group of Hospitals, which was mentioned. So last 15 years I've been doing EBUSs, and I've got a very competent team now who joins in doing it. So very briefly, I will be very brief about the technical stuff, the key differences between the radial probe EBUS and the convex probe EBUS. The fact that the angle of view is much greater in radial probe EBUS. I just showed you a photograph. 360-degree view is what you get in radial probe, and 90-degree in convex probe EBUS. The penetration that you see is far lesser in radial probe, much greater in convex probe. The resolution is better in convex probe. The airway visualization with balloon inflation is better in radial probe EBUS. And real-time sampling and Doppler is possible in convex probe, and not in radial probe EBUS. So that's the working comparison between the two procedures, which are actually quite different. So 2006 till today, these are the three scopes that are mainly available in our country. So that's the Olympus scope, that's the Fujinon scope, and that's the Pentax scope. So we currently work with both the Olympus and the Pentax scope. The main difference between the three scopes is the degree of angulation at the tip. So just at the bottom there, you see the direction of view is 30-degree forward oblique for the Olympus scope. For the Pentax scope, it's 45-degree forward oblique. And for the Fuji film, it's 10 degrees forward oblique. And you see that when I showed you the photographs of the three different scopes. Quickly do a couple of cases which illustrate bog standard EBUS and the newer techniques that are being done by myself and the team just now. So this is a 41-year-old male, dry cough for the last 2 months, fever which is low grade for the last 2 weeks, and had 2 courses of oral antibiotics, started on inhalers, symptoms did not resolve, and you can see the nodes on, so ideally we would have a mediastinal window, but this shows the nodes on there across the pulmonary artery, and you can see on the X-ray the bulky right hilar which shows up on the corresponding CT scan. So this looks at 120, so the Chinese study which looks at about 120 odd cases where you had a CT-guided core needle biopsy through the mediastinal node through a transpulmonary approach, and it shows the complication circled on there. So significant numbers with pneumothoraces, a third of patients ended up having pneumothoraces, and hemoptysis at about 5%, which is also not a small number. So these are procedures which are risky, there's a risk attached to it. There are certain indications which are outlined here, which I won't go through for the sake of time. But just to remember that when you do a procedure, any procedure, the risks that you take and the benefits that you gain need to be balanced against each other. Just a tool and to do anything with the tool often results in more damage than good. And that's not just with transvascular access to nodes, but with any procedure that you do. And this is a cartoon of showing a lymph node puncture. I know this is not very well visible, but that's a cartoon of the scope, the needle coming out and going through the lymph node. And that's the corresponding pictures of the patient that I spoke about just now. That's the 4R node. That's the station 7 node, a much larger 4R, a comparatively smaller 7R node. Let me show you the picture on here in a moment. That's the procedure, and I'll just drag this through for the sake of time. So you can see the needle going out, and then on ultrasound Doppler on a moment, you will see the vessels. So the aim is to make sure that your needle avoids the vessels. You can see how the needle is going through between the vessels, and that's how you maintain the security of the procedure and prevent bleeding from the procedure. So that's a bog standard case that we saw. It was transvascular, but it was reasonably safe to do given the circumstances. This is the second case. This is the 40-year-old man who is unable to lie flat for the last 3 weeks. He feels palpitations, pressure on the chest on lying down or reclining. He has chest discomfort, he has a dry cough, and he has shortness of breath on exertion when you take a history which dates back to 2 months. He's consulted his family physician who's given him inhalers, antihistaminics, etc., and then asked for preliminary investigations. And you see this poor quality chest X-ray and then a better quality one beneath where you see a lot of mediastinal widening. That's the mediastinal widening. Let's show you the CT, which is very interesting. That's the CT. And again, I'll drag it through the point of interest. You can see this large cystic lesion which is compressing both the aorta and the pulmonary artery. And that's the reason why this patient has the degree of breathlessness, chest tightness, palpitation, etc. that we spoke about. So ideally, you would go for a surgical procedure for this individual. So Sham was called to the operation theater because as soon as the patient lied down in the OT, even without the anesthetist doing anything, the patient started developing arrhythmias. So he couldn't lie supine, so was called out to the operation theater. You've seen the CT already, so I'll skip that and I'll show you some pictures. of what we did. So this is looking at the cyst itself, and what I want you to appreciate is the thickness and the granularity of the fluid. So the plan was to put the EBUS needle in and then aspirate liquid. You can see the needle going in and aspirate liquid out. However, unfortunately, the fluid was so viscid that the fluid wouldn't come out with the EBUS needle. So what Shyam did, and I'm sort of presenting this case on his behalf because he's the person who did it, was to use an electrocautery needle. He's called it the Gordian knot moment, and we'll come back to what that means. But yeah, so where are we? 1 second. So you can see the electrocautery knife making a nick on the wall of the airway, and then he put in the sheath of a TBNA needle through it, and then aspirated the liquid out just to shrink the cyst in size. So you can see the sheath of a TBNA needle going in, aspiration, and that's what we got out. And as a result, you can see the shrinkage in the size of the mediastinum. You can see, so these are pictures that you saw previously of the widened mediastinum. This is what we had after, and I'll show you a CT thereafter. And on the CT, you can see the cyst is now reduced in size. The patient can now lie flat without experiencing the arrhythmias and the chest tightness that he was feeling, which is why we got summoned to the operation theatre. The patient had the cyst taken out thereafter, and the histopathology confirmed that there was a bronchial cyst in this case. Let's go to the last case. So this is a 50-year-old man, smoker, hypertensive, a previous history of a pacemaker insertion, who presents with a dry cough for the last 3 weeks, worsening breathlessness, unable to lie down flat for the last 7 days was his complaint. And again, you can see a lesion over there. You can see the upper part of the mediastinum again widened. So that's what the chest X-ray showed. Let's look at the CT together. And just further down, yeah. So further down, you can see a mass there in the right parahilar region. And then further forward, what I want you to appreciate is the large, moderate to large size pericardial effusion. So you see the pericardial effusion on there, you can see the parahilar mass on there, and it was the pericardial effusion which was making this patient breathless when they were trying to be supine. So what did we do? So this patient couldn't lie flat at all. So this was a patient, we had to do the EBUS sitting up, and we had an Optiflow Thrive which we used to do this case. So we'll come back to what's the difference between HFNC and Thrive in a moment, but the fact that it can deliver 100% oxygen with a 70-liter flow in these patients. So that's myself and Shyam in the operation theatre, in our bronchoscopy unit, doing the case, and you can see the patient propped up on there. That's the Thrive. So that's what supplies oxygen at 100%. There's rapid insufflation of heated, humidified gases. It can actually do apneic oxygenation with ventilation through a high-flow nasal cannula. So the cannula looks very similar to the HFNC cannula that all of you would have seen. It allows oxygen titration up to 100%. You can create a PEEP up to about 10, which prevents airway collapse and atelectasis, and that's how it's different to using a HFNC cannula. Let me quickly show you the case in a moment. So that's, drag this forward. So what you see first on there is the mass, and this is in the 4R position. You can see the mass being sampled with the needle going into the mass. And then further up, the patient was still breathless, still propped up. So we went in and did a USB, and we drained the pericardial fluid through the esophagus. So that's the pericardial fluid being drained through the needle. So again, the histology came out to be a non-small cell lung cancer, both from the pericardial fluid and from the lesion. Rose was done, and the lesion showed an adenocarcinoma. So the reason I showed you the next two cases is the evolution of EBUS from 2006 in my case to what we are doing currently. We're very capable people doing cases now. We're doing cases with indications which are probably not that much in black and white. I showed you a bronchogenic cyst. You can look at pulmonary thromboembolysis through EBUS, even though that's not an indication for doing it. But sort of broad spectrum, so finishing last 2-3 minutes, there's a wide variety of procedures in the realms of interventional pulmonology, and there's a lot of people, including Dr. Lokesh Gupta, Dr. Nagarjuna Maturu you saw, and a whole host of others who are doing these procedures with great efficiency. However, the other thing that I think has changed a lot is the interdisciplinary approach. The fact that you have radiologists who can interpret the difficult HRCTs or CCTs, identifying the mediastinal nodes, the ones to sample, the ones not to sample. If there are parenchymal lesions, whether you would do a TBLB or a cryobiopsy in these cases, the radiologist helping the pulmonologist to plan the size of a stent are all factors that you can depend on if you have a good radiologist handy. And similarly for pathology, who would look at your EBUS sample, whether you can do a ROSE, which is rapid on-site evaluation, versus PROSE, which is the pulmonologist doing ROSE, and who would do a frozen section in your cryobiopsy so that they can tell you the diagnosis immediately. So I think I was introduced as an interventional pulmonologist, but for me, this is something which is a part of my diagnostic or management armamentarium. I think while there's a vital need for people doing interventional pulmonology, it should, in a majority of cases, other than the very best tertiary care center, be a part of the diagnostic armamentarium, with the very difficult procedures being left to people who are the interventional pulmonologist. We need to make sure that the procedure that you're doing is actually indicated, the procedure merits being done. Make sure that people doing it are trained to do it. I think the important thing is to be safe and make sure, like I showed you a little while ago, that the benefits outweigh the risk. Important to work collaboratively with your radiologist and pathologist, and please keep data. Look at your data from time to time, work with different centers together, try and publish the data. All of this is very important. And this is a bit about training. This came out in Respirology a year ago actually, which looks at various procedures. There are two numbers that you can see. So two numbers that you can see. This is about EBUS. The 40 denotes the number of supervised procedures that you need to do, and the 25 denotes the number of procedures that you need to do in a year to keep up your competency. And you can see that the numbers vary a little across the various international guidelines, but they are more or less similar, and you have other procedures that are listed on here. So this is just to emphasize that training is important irrespective of which facet of interventional pulmonology are you doing. And for this training, you have these wonderful simulation labs which are coming up even in our country. You have virtual simulation on there. You have the mannequins, which we are all familiar with, and the mannequins have gradually got better over a period of time. So I think my journey in doing EBUSs or interventional pulmonology over the last 18 years now gradually evolved to understanding that all of these procedures have complications. There is a risk of doing harm, and you have to be circumspect, you have to be safe in doing procedures. And I'll repeat myself when I say that a patient needs to deserve a procedure before you go on to do them. Make sure that all of you train well. I'm sure a lot of you here are well trained already. But for people who are training, make sure you train well, you're adept at doing the procedure before you go on to do unsupervised procedures going forward. I think EBUS is now an essential part of the training of any pulmonologist. It's important that you learn them today. And there are other procedures which are more cutting edge, which you will learn depending on where you train. So that's my story. Thank you very much for listening. I'll be very happy to take questions.
Thank you, sir. I would request Dr. Lokesh to present a moment.